Welcome. Today, we're going to talk about our technology on endoscopic multimodal imaging for guided surgery. Various imaging modalities developed over the past few decades, such as MRI, ultrasound, PET scan, and other technologies, have become indispensable tools for preoperative screening. However, translating these still images into the surgical theater still remains a major challenge. That's because the tissue is soft and moves around. So as a result, in daily surgical practice, the surgeon has to rely on the visual perception and maybe palpation when it's possible. There is a well-recognized need for development of new intraoperative imaging modalities. The examples shown here represent a new technology under development which uses fluorescent contrast agents. Those contrast agents can target specific anatomical structures such as disease, for example, cancer, or other structures that need to be preserved. In the example here, on the left side, we show a tissue that contains tumor, and the fluorescent contrast agent localizes on the tumor and makes that visible using fluorescence imaging. On the right-hand side, there is a case where we're trying to preserve some structure, and then in this case, the fluorescent contrast agent is localizing there and makes its presence visible. Fluorescence imaging is a recognized and rapidly developing technique and allows the selectivity in the imaging process and allows for highlighting the features that need to be preserved, such as anatomical features of importance or features that need to be removed, such as cancer, and examine margins. We have been working on this topic for over 15 years, and the picture here shows our product prototype that incorporates this technology. It has been designed to provide maximum sensitivity, and it's been designed to be adaptable to any type of endoscope. In this particular case, it's attached to a laparoscope, and the attachment from the tip of the laparoscope is transferring the image into the box where it's analyzed. At the same time, the box provides a specialized lighting that not only provides for visible imaging, conventional imaging, but also provides for excitation of the chromophore, which subsequently emits and provides visualization of the target area. This is a system that is different to what has been shown in the literature in recent years or is commercially available. The system on the lower side here is a robotic system, and really our technology does not try to cover this area. Our technology is actually trying to cover the area where the system is adapted to existing endoscope, and it becomes less expensive and it becomes more flexible. In the image on the top, we see a published picture of a different system, which is capable of simultaneously providing the color image and the fluorescence image. And in doing so, it involves certain compromises. Those compromises, which I'm going to discuss next, have been resolved in our technology. And as a result, our technology provides multiple orders of magnitude higher sensitivity. Our design differs from what's currently available or has been shown in the literature by the way it acquires the images, which provides for an orders of magnitude higher sensitivity. The currently available systems acquire simultaneously the color and the spectral image by alternating, and the camera alternately acquiring one or the other image. In order to have real-time image acquisition, the frame rate of the color image needs to be high enough in order to be looking as a real-time image. That restricts the time that the spectral image can be acquired. In our technology, we have separated the two, and the color image is acquired at a rapid rate, so it's real time, while the spectral image is acquired at time intervals that provide sufficient high image quality. That means if the signal is very low, the acquisition would be longer in order to acquire a high quality image, as opposed to having to be locked into a very specific fast image acquisition where there would be no image when the signal is low. This is very important in this technology. I will demonstrate our capabilities and our technology for the case of visualization of the anatomical structures of the biliary tract. The laparoscopic management of the biliary disease has become widely accepted and practiced. Over 750 patients undergo laparoscopic cholecystectomy in the United States. Common bile duct injury is a problem and happens in about 1 to 200 cases, about 4,000 per year. That then leads into significant problems. It may require multiple surgeries, up to may require a liver transplant. The cost of those operations and the liability is very high. And those errors happen because the surgeon fails to identify the structures of interest in this case. Although here we're demonstrating the case of anatomical structure of the biliary tract, the very same principles are applicable into any other case where targeting fluorescent contrast agents need to be used, such as for cancer detection, for example. During laparoscopic biliary surgery, intraoperative cholangiography is the standard practice. That requires cannulation of the cystic duct, which leads to associated complications, which can involve infection, bleeding, inflammation, or damage. It takes 10 to 20 more minutes exposure to radiation, and still the image is not live. It's still, again, an image that represents a particular moment in time and is not directly overlaid into the surgical field. As a result, the interpretation is dependent on the operator, and errors can happen because of the visual perception illusion. Only 3% of the errors are due to technical skill related. And that raises cost-to-benefit issues. Recently, it was shown that ICG, a chemical compound that is FDA approved and is fluorescing in the near-infrared, can be used for highlighting the biliary tract. Specifically, ICG is administered intravenously before surgery and then is excreted into the bile through the liver. That makes the bile duct system fluorescing. And in this particular case, the example shown is in open surgery, and the lower right-hand side image shows the operator holding a big camera. We want to do this using a laparoscope. We want to demonstrate this technology that can happen laparoscopically. And that's the goal of the work I'm going to show you next. This is very exciting work, and lots of publications have been produced in the last 4 years along these lines. Now, here is an example using an animal model. We can see on the right-hand side the color image, and on the left-hand side the fluorescence image. It shows the gallbladder and the bile duct, and one can appreciate how clearly that bile duct system is visualized in the fluorescence image. The biliary tract lies in the Glisonian stealth and is buried in the perivascular, connective, and fatty tissue. So it's difficult to clearly visualize and isolate during surgery. It is an objective, a main objective of this technology, to be a navigation tool and be able to see below these tissue layers. In this particular case, we simulate the presence of dense tissue on top of the biliary tract by having a small tube the size of the biliary tract, 3 millimeters diameter. Typically, the bile duct size is on the order of 3 to 10 millimeters. And then superimpose on that dense tissue, which is in this case is muscle, bovine muscle tissue. We can appreciate that the color image in this case, which is the middle image, cannot visualize the tube underneath. But when we turn on the fluorescence image, now we can see below the surface and see the location where fluorescence is present. In this particular case, simulating the bile duct system. So this is really important. Here is another example where we have, again, 2 layers of intestinal wall positioned on top of the bile ducts. And when we turn on the fluorescence image, we can see the bile ducts underneath those dense connective tissue of the intestinal wall. And one can actually create composite images where the two are superimposed and can be provided in real time to the surgeon, where the visualization of the subsurface structure will become apparent, so it can be used for navigation. So what we're trying to show here is that with very sensitive instrumentation, one can expand beyond what is visible. And in this case, the top images show what is visible in the example shown in the presentation, the muscle tissue and the intestinal connective tissue walls, and can see behind those, well behind those, and detect what is the feature of interest that we need to preserve. And we can create composite images that can be presented in real time. In conclusion, our system design offers optimized sensitivity and functionality for endoscopic, laparoscopic, fluorescence, subsurface imaging. It is designed to be able to adapt into any type of endoscope currently existing, and is designed to provide optimal sensitivity so we can see deeper into the tissue and we can use minimal amounts of fluorescent chemicals. The design could provide a low-cost, real-time surgical navigation capability for minimally invasive surgeries. And it can be used in a variety of cases, such as for cancer detection, cancer removal, visualizing the bile duct as shown in this particular case example in this presentation, and also preserve other types of important structures, such as nerves, vessels, etc. In general, it can be used with any fluorescent contrast agent that provides targeting localization in specific tissue structures. For more information, please contact the LNL IPO office. Thank you for your attention.